Okay, I'm just going to get started with introductions, and folks hopefully will be coming in from their meetings and sessions and all of the things that we all are doing today. Welcome. You are at the second Justice Provider Strength Series. Yeah, I'm going to put the link to the first session that we had. I'm going to attempt to do this. I will put the link to the first session with Chad Shubin that we had just 2 months ago into the chat before everyone leaves, so that you can watch that session if you'd like. So throughout the hour, please feel free to use the chat, audio or video. Our hope with this Justice Provider Strength Series is that it's really a peer-to-peer event that allows for dynamic conversation. So please feel free to participate as you are able to on your side. I know we're all coming into these virtual events with different circumstances, but please feel free to participate if you are able. So I'm just going to flip the slide here. As we're getting going, if you don't mind, add your name, the program that you're working for or coming from, the school you're attending, if that's applicable, and your email address. If you want your email to remain private, you can send me a direct message in the chat or email me. Really, I just need your email so that I can make sure you get the link to the CEU quiz for today's event. So to gain a CEU, I'll send the link on the chat. I'll also send it by email. It will be a short evaluation with a few questions, and I'll get that certificate back to you. The CEU will be available if you have any staff or team members that you'd like to come back and do the CEU at another time. It's going to be available for 6 weeks on YouTube. So really, you could do Chad's session and this session and get 2 hours of CEU credits. Our hope is that we're offering this every other month, so that in 1 year there's 6 CEUs available. Right. So we're going to offer it on an ongoing basis to highlight practices that align with what research tells us decrease the likelihood that an individual will engage in future criminal behavior. My name is Jessica Seawright, and I'm a research analyst with the Utah Criminal Justice Center. Some of you who are on the call have been kind enough to welcome me into your program, and that's kind of where I'm coming from for this work. I've worked at the intersection of social work and criminal justice for almost 10 years and completing program evaluations for almost 5. I've evaluated adult and juvenile programs across the state of Utah using the correctional program checklist. So I just want to give you a little context about that. Thank you all for putting your emails in the chat. Here we are today. We are working our way to Brett Bartruff, who will be speaking more. But I just want to give you a little background. Coming from the Utah Criminal Justice Center, if you want to learn more about us, it's ucjc@utah.edu is our email, ucjc.utah.edu is our website. Now the CPC, it was created by researchers at the University of Cincinnati, and it's used to identify how closely correctional programs are meeting the known principles of effective intervention. The CPC aligns with research on risk, need, and responsivity, or RNR, which may come up today. Several studies were used to validate the indicators in the CPC, and you can learn more from Ed Latessa and his colleagues from what works and doesn't in reducing recidivism, including why program quality is important. Now, this is a text that we looked at during our past reading group, so that's also available on our YouTube site. So what brings us here today? The takeaway our team had when we were doing CPCs across the state is there are so many strengths happening in the state of Utah. There are so many great practices that providers are currently doing. And so that's the goal of today's event, to share and cultivate what is working in Utah and to open up dialogue about about practices and how to balance research in our day-to-day practices as providers. So I want to offer some scope, which is that we're looking at recidivism. Recidivism is measured by criminal acts that resulted in rearrest, reconviction, or return to prison with or without a new sentence during a 3-year period following the prisoner's release. Now we might kind of reframe that and use person-first language. So what we talk about often is that folks that are justice involved and maybe court mandated to treatment. This definition that I offered was from the National Institute of Justice. So with practices today, we'll be focusing on what increases the likelihood that an individual will engage in future criminal behavior. Let me just compare. There we go. So criminal justice researchers have asked, what are the factors that are correlated with criminal conduct? In 1998, researchers Andrews and Bonta identified a set of major risk factors, which have been confirmed with subsequent studies. So those are listed here. I'm not going to read them all to you. Maybe you can say if in the chat if you're very familiar with these kind of need factors. And that might help give Brett an idea of who's here with us. Now, as providers coming probably through the Division of Substance Abuse and Mental Health as public or private providers, you may know that some of the risk factors are static criminogenic risk factors that we cannot change. And then there's dynamic risk factors that we can change. So really our purpose here today is to talk more about using validated screening and assessment tools that we want to target risk factors that are assessed as higher for that individual and the factors that we can change. Many of you here may know that, that substance use is right there on the bottom. Substance use is one of our criminogenic risk factors. And you're familiar with how that contributes to a lifestyle that could bring individuals into contact with the justice system. And hopefully you're familiar and passionate about how clients can change those behaviors around substance use. We want to encourage through this series looking at the other dynamic criminogenic risk factors and seeing how folks can change those as well. So today we are going to focus on the implementation of validated screening and assessment tools, like the suite of tools from multi-health systems, including the LSCMI, the LSIR screening version, LSIR-SV, or the full tool LS-RNR. Now, UCJC and myself, we're not affiliated with multi-health systems, and there are other risk need assessments that you may know of, that you may use, that are validated and work for your teams. Our UCJC director co-created the Women's Risk Need Assessment tool. So that's an example of another risk assessment you may be familiar with. However, today we're going to focus on the LSIR, the multi-health systems tools, because the Division of Substance Abuse and Mental Health has started to offer the LSIR screening version to providers to start to implement in your own practice. And we're lucky to have Brett Bartruff here to share his experience from Davis Behavioral Health. And how they've used the LSCMI and starting to use the LSIR screening version. So that was a lot of words. We can return to some of that detail on the CPC that I cruised through, but I really want to stop and allow Brett to have the floor here and discuss the practices that they have at Davis Behavioral Health, and definitely get to any thoughts you all have about these practices as well. So I'm just going to stop sharing and turn the time over. Thank you all so much for being here.
Thanks, Jessica. Let me just launch my presentation. Okay, are you all able to see my screen now? Great.
Good, thank you.
Great. I just want to say thank you to Jessica. I appreciate the invitation to come talk about this. My name is Brett Bartruff. I'm the Director of Substance Use Treatment and Recovery Support Services at Davis Behavioral Health. When Jessica first asked me to talk, I was like, I don't know how long if I can talk for a half hour about criminogenic risk screening. And then I was like, I'll fill some time and talk about DBH, which will allow me to lessen my anxiety a little bit as well about speaking. So Davis Behavioral Health, just so you're all familiar with my agency, began in 1972. We were Davis County Mental Health at the time, before we, through mutual agreement, split and incorporated into a 501c3 nonprofit. We are the local mental health authority and local substance use authority for Davis County, which means we provide mental health treatment for the Medicaid, the traditional Medicaid population, the capitated Medicaid population, as well as substance use treatment to anyone in need of our substance use treatment in the county. Our goal at Davis Behavioral Health is just to be indispensable to our community and provide service to anyone, care to anyone that asks for it. We do incorporate a lot of grants. We have a small private insurance clinic just to help further our mission of being able to provide services for more of that unfunded population and serve those persistently mentally ill clients and clients with severe substance use disorders and high criminal risk. Our substance use program. So we provide ASAM levels of care, residential, intensive outpatient, general outpatient. We have a program we call RSAT, which is jail IOP services inside the Davis County Jail. That's a cohort living model. We have a very large medication assisted therapy program and provide, we don't provide methadone here, but contract out for that. But we really have incorporated MAT into our programming and have found it really beneficial. Also under our substance use umbrella is our new receiving center, which is a short-term stabilization and charge diversion program for people with mental health or substance use conditions. We really try to target those that may be picked up by law enforcement because they've had an interaction due to their mental health or substance use issue that can avoid charges by coming and getting engaged in treatment and offer short-term stabilization, including social detox. Also, we have a very large recovery support program, which is peer-led by certified peer support specialists. They offer case management, intensive dropout outreach to prevent dropout from substance use treatment. They offer assistance, financial assistance to remove barriers to recovery. They have some financial resources to help with that. We have an ED response team that presents to an emergency department when a client presents with a mental health or substance use condition that's not requiring hospitalization. We have a comprehensive continued care program, also known as aftercare, peer-led groups and social activities to engage clients in. And then we also have the parolee access to recovery program. We serve about 1,000 unique clients every year in DBH substance use treatment. Yeah, across all of our levels of care, we have 20 or more clinical master's level clinical providers, 1 SUDSI, 10 residential and community-based recovery support case manager peers, and then a lot of residential and receiving center techs. So Jessica covered some of this and had better explanations than I probably have here, but just to kind of go over the RNR model, the general personality and social psychology underlying the risk needs responsivity model of rehabilitation recognizes the importance of the personal, interpersonal, and relatively automatic sources of control over human behavior, as well as the power of cognitive social learning approaches to interpersonal influences in many social settings. First task is to help keep low risk cases low risk and not interfere with existing strengths. The second task is to identify moderate and high risk cases and arrange crime prevention activities consistent with the ethical, legal, and just applications of principles of RNR. So those are really good, really well worded explanations. My bad attempt to offer a simple explanation of criminogenic risk assessment is a holistic approach to assessment of a person's risk by identifying their social, behavioral, cognitive, both dynamic, changeable risk factors, and then their static risk factors and the potential for recidivism, and really a focus on individual strengths, which is this byproduct of implementing specifically the LS models, is identifying unique strengths, which has been really great. I'll talk about talk about a little more. So DBH's process, how we implemented criminogenic risk screening, we started, and I don't have exact dates for all of this, and I actually wasn't in substance use leadership at the time of full implementation, but I was working as a therapist actually when we started really to try and incorporate and address criminal risk. And I remember we actually started using some of that language and were told to incorporate treatment of criminal risk prior to the LSI, prior to criminogenic risk screening. And it was really based on just clinical judgment. So our efforts started years before we had formal assessment, was based on clinical judgment, which resulted in more of like a blanket approach and less individualized approach to treatment. So everybody had a reduce criminal thinking treatment objective, and everybody had a reduce pro-criminal relationships objective. But we had this process that we were starting to already have that incorporated into wanting to treat that. And we actually at that time started building it into our peer review process and had it on our peer review tool to see that it was incorporated into the treatment plan. But again, it was our judgment at the time of whether somebody had high criminal risk or not, or what areas they did. We were getting, for like our drug court population, we were getting, I'm blanking on the name of the tool, but we were getting something from them that did have identified that the person was high risk and high need. But that's the extent of what the information was. It didn't give us like specific areas that they were in. We just kind of got the score sheet. We got in March 2017, which I, for some reason, really thought was earlier than that. But in 2017, DBH got all ready to be trained in the LSI. I think we were thinking we were going to get trained in the LSI RNR, and our director at the time, like, he was a very organized individual and process driven, really great. Got us everybody scheduled, all of our therapists scheduled for this training, ordered us materials, had the scoring sheets and the manuals, and then the trainer showed up, and I don't know how this exactly happened, who said, "I'm training you in the LSI CMI," which is just it is a different tool, similar risk rating, but includes a case management portion. So all of our therapists got trained in that. We did have to buy all new manuals and all new papers. The LSI CMI is a pencil and paper inventory that is filled on a paper that we order from MHS. We also our goals of this were to come into compliance with our division directives to make sure that we were addressing and sorting criminal risk and determining whether somebody was low or not low risk. And we wanted to sort out, like the other goal of criminogenic risk, we wanted to sort out low risk offenders. We, are aware of the research that when you mix low risk offenders with not low risk offenders, you make not low risk offenders and make better criminals. And our goal was not to do that. And interesting, really, I think interesting, our, just clinical judgment that we were doing before, we were okay at identifying like high risk individuals. We were really not good at identifying low risk individuals. That was, we found that overall that we would generally kind of rate people higher, and then that moderate risk was, we were either rating higher or often putting those people in low risk too. So that low risk category is where we struggled the most. So all of our therapists were trained in the LSCMI. We complete it at the time of evaluation. Our goal is to complete it at reevaluation anytime we do a new assessment or level of care change. And then upon discharge, we would do our evaluation, and then the end of the evaluation session, pull out the LSI and complete it with the client. And we only are doing the risk assessment portion, the first portion of the LSCMI, and our providers have not been doing the case management assessment section and just getting the scores. And then we actually record those scores into our electronic medical record as part of the evaluation. And each section of the LSI has a score, and then there is a summary we put at the bottom of the identified risk, the higher risk areas, and should be identifying any strengths. We do the paper form, and then at the end of the session, at the end of the evaluation, we actually shred the paper because we have recorded those scores inside our electronic medical record. As I said, we already had this part of our peer review process, so we were pretty confident. It took some time to get it up and going and implemented, but we had a check and balance system for that. Just covered some of these, but real quick, the areas, the LSI CMI specifically cover for criminal risk rating or criminal history, education and employment, family, marital, leisure, recreation, companions, alcohol and drug problem, pro-criminal attitude, orientation, antisocial pattern. Scoring is generally a yes or no response. There are some responses that are a 0 to 3 Likert scale, or also identified as an area could be identified as a strength. The anchors and definitions for those anchors are really well done. So scoring is pretty objective. Even the strengths is pretty well anchored. So it's pretty objective, and iterator reliability on it is good. We have found that with our providers, having people that have had relatively close evaluations and 2 providers completing an LSCMI and getting in the same score range, which is really nice and helpful. So how did it help us? How did criminogenic risk screening help DBH? Prior to being trained, most of us thought about risk relative to clients as like their substance use intensity, the intensity of their substance use disorder. We really thought concept of somebody's criminal risk was all about criminal history, cognitions, thoughts towards crime, and criminal associates. Like, we just got way better at identifying specific dynamic risks in all of those areas. As you can see, like, there are various domains of criminal risk that somebody without a criminal history can still score moderate or high or very high with no criminal history in that section. We also accomplished the goal and got good of separating out low and not low risk clients. Eventually, I can share about this more later, we became in compliance with our division directives of having that reflected in our EMR way after actually we had the process up and going, but we did become finally in compliance, which is great. And those were really good goals and what we're really setting out to do at the time. But these like way better benefits and a little unintended, we got way better at treatment planning. Like it was really easy to identify the areas that were high risk and to then create a goal for a dynamic risk factor that this client does have criminal thinking to address that, or criminal associates. And I mean, it made it easier to identify those things. And then we saw way less of the blanket everyone had a criminal thinking objective. And because it was easy as part of the peer review to say, well, you wrote an objective for criminal thinking, yet on that specific domain, they scored low. we were just able to understand and discuss risk much better, especially with like when we're interfacing with our criminal justice professionals, court systems, POs. We just got better about sharing the same language and talking about specific needs of a client. Like we would get requests from court programs like, what does this client need to work on in treatment? And just helped us use language that they understood we need to address. And at the same time, the criminal justice system also seemed to be getting a lot of education around criminogenic risk. I remember it wasn't too long before being in the drug court staffing and talking about one of my clients, but too long before I got trained in the LSI and talking about their risk and how this certain thing like increased their risk. And then after I got trained, being like, I really didn't even know what I was talking about. I couldn't say specifically this is where it elevated their risk and would change the response on the questionnaire here, which would increase their risk. Also, we got good about our continuum of care. Like I am somebody, like I really have a belief in the continued care model, and that addiction is a chronic brain disease that requires often treatment at different intensities and different levels throughout a person's lifetime. And so having them connected to treatment and understanding how their risk increases the need for that continuum, it's helped us understand that, and it helped us sell recovery services, continued care services to our providers more, that they saw the important, when they would be working on somebody about their criminal associates and having more leisure activities, they can sit and talk about it in the therapy office for an hour. Then the person has to get up and go do that. It became helpful to be like, well, there's this activity tomorrow to go bowling that's focused on recovery. Show up then. It really helped us sell that. And this about identifying strengths, we saw in our assessments, the assessment of strengths went from like, they say they're really nice, or they're really, they really value their family, to specifically like they have maintained employment for this long, or they have been able to get along with their coworkers. I mean, just it was helpful to identify strengths that we just sitting down to be told you're going to learn about criminogenic risk, didn't think we would learn about identifying strengths better. Some things we hope to continue doing and to do better. This treatment of low risk individuals, I feel like this is like the whack-a-mole like thing I've worked on for years. And we got to it, like we found we were removing them and offering specific group intervention for low risk individuals that was kind of more psycho ed based. And we actually worked on a referral system from the courts to get more of this population, got that up and going. And then the pandemic hit, and we canceled all groups. So we weren't providing those groups. I mean, it's just been we're trying to get back to that. And now we are having a hard time finding enough people to come to those groups. So we would love to get better at providing treatment for low risk individuals. And DBH's core population, other core population besides substance use, is the severely mentally ill population that often needs substance use treatment. We want to provide good treatment for them when they're on the low risk spectrum. We would also love to have more evidence-based practices for criminogenic risk. Our go-to group modality is MRT, which we do a lot of. Again, during the pandemic, that disrupted, and we're getting that model up and going. But we would love to invest and find more EBPs for high criminal risk, especially individual-based interventions. We also want to just continue to break down barriers between our mental health and substance use treatment services. So often people that come in through our mental health services are in need of substance use treatment and may not have LS, have a criminogenic risk screening and need to be referred to our program. And I may get a referral and I have to say, well, I need to come do an assessment to determine if they have high criminal risk or not low criminal risk to attend the services I provide. So we're looking to expand the screening into our mental health population so we can make referrals easier. So we are moving towards away from the LSI CMI, and I know there's a lot of the private industry has moved towards this or is also moving towards this. I think we are one of the first locals that have been given the opportunity to do this. We've been wanting to train more people in the LSI process, as well as get some of our mental health people trained and our case managers trained. So we were excited to hear about this. And so the division told us about this opportunity to switch to the LSI RSV, and the pros were super excited. It's computer-based, not paper, so we don't have to buy the paper forms anymore. It is a good bit shorter than the LSI CMI, as it's just the screening, which is cool, can save time. It'll also be way cool that the JRI centers will be, and eventually the substance use authorities will all use the same system, all use the gear system. So that will be cool because we'll all be on using the same tool and be able to talk about it. And if there's clients in between, we can easily share that information. So to be strengths-based, the not pros is each client has to be entered into this system, which means every provider. So at DBH, we trained all therapists to do it. We have switched to a model now where most people come in and go through my evaluation clinic. So I have 2 primary providers that do all of our new evaluations, but therapists are updating those when they should be updating those when somebody changes level of care. It's a lot of people to have access to that system. It also is much longer process to log into the system and enter a new client into the system and record it than pulling out a piece of paper that actually we don't even need to write the client's name on. We're just using to score and then shredding. It is just a longer process. It's also a different tool. I thought I could just, when I got the login and went and looked in it, I'm like, it's probably really similar. We can just figure it out. And we weren't able to. So we need some training. We ordered the training material. I just got an email that Tom at the division is gathering everybody to be able to do a training with MHS on the new tool. So that's cool. And then I hear this in my head right now, like, even though my providers do not know that this change is actually coming, but it's just one more thing. Every time there is a process change, there is a new change. Is difficult for the people that implement it, that have a system down that they're used to working in, and changing that model. And so I'm getting ready for that resistance and helping people work through it, even though it is replacing something that they're already doing with a shorter screening. It is just that I just can hear it in my head from specific people too. Just one more thing. So that is something we're getting ready for. If anyone has actually implemented this, if you have feedback or responses of how you overcame some of that change of the time difference that it takes, I would love to hear any of that. Great. Are there any questions for me?
Yeah, thanks so much for everyone joining. Any questions?
I have a question. I'm not sure how to ask the question. It's in my head, but I'm not sure how to say it. But how do you incorporate the criminogenic risk factors into the actual treatment plan?
Mm-hmm.
Yeah, good question. So the areas that are of domains, they'll like criminal history, education, employment, family, marital, all of those have, some of them are dynamic, changeable risk factors, and some of them are static. If somebody scores high in education or employment, we write specific goals in that section to specific behavioral or cognitive objectives decrease their criminal thinking or increase their adaptive behavioral skills. That's how it kind of guided us. If somebody scored high in that area, we would address it. We would write an objective to address it.
Okay, thank you. I have a follow-up question. So, like, we have gotten feedback from the county when they look at our treatment plans and they say, okay, so, you know, how do I know which one you're targeting? What, you know, risk factor you're targeting? And so, do you normally, like, somewhere in the treatment plan, identify if it's, you know, family or if it's antisocial behavior within the treatment plan? Because if I'm looking at the treatment plan, I can already see which one I'm targeting, but that's because I'm familiar with, you know, the criminogenic risk factors and all that stuff. But apparently, some people are not. So, do you actually just write it on the treatment plan what area you're targeting?
Yeah, I think what we have done is just try to use some language from that domain, like criminal history or education and employment. Yeah, that we've tried to not specify this specific domain, but tried to pull in language from that one. That has helped us. But I have also seen that specific thing that you're talking about. Like, I can read an objective and be like,
Right.
obviously this is targeting somebody's pro-criminal associates or antisocial behavioral patterns, but others may not be able to understand that. So yeah, the more specific from that language, the better. Yeah.
Thank you.
Thanks.
I guess I would ask as well, where exactly do you fit it in your initial intake and screening process? Because I was just jotting things down, and to speak to your staff's concerns about one more thing, I mean, I wonder about that. If we've got the LSRNR, in some cases the GAIN, the GIPRA, we would be replacing the Rant. The SURE now is coming.
Yeah.
DSM screenings and evaluations there, the CSSRS, the AZAM screening tool, and a psychosocial history. When on earth are we going to do therapy?
Yeah. Yeah. So I can't answer all of those. I can tell you, though, that this seemed to be, we were really worried about that exact thing. This seemed to be less painful because what we found is that we did our normal biopsychosocial evaluation with somebody and then pulled this out at the very end. Almost all of the questions, the provider was able to go to indicate the response because they had just done an evaluation. If I remember correctly, there were like 2 questions that I would have to bring up to the client that weren't part of my normal assessment. And some people were just able to work those in. So we found that after people knew the tool and had implemented it, it didn't extend our evaluation time more. We had originally actually budgeted to increase by the half hour that it said that an interview could take. And we have found that we just were able to answer this based on the evaluation. And then when somebody is doing a reevaluation, they are familiar with that client, their evaluation, and their history. And so it is much quicker than sitting down with somebody you don't know and going through the questions cold.
Brett, then to speak to that as a follow-up, so what has it increased in the way of, I guess, record keeping, documentation, and then reporting? Because the idea would be that if somebody's getting this information, at some point in time with us moving to event-based data, there's going to be an increase in reporting as well. And if that's, how often are you having to do it? Is it just at intake? I mean, are you having to follow up and do other versions of this as you go forward? I mean, with there being dynamic risk factors that may change, I would be loath to suggest that the state isn't at some point in time going to make us do this over and over and over again.
So you're going to stretch my understanding fully of reporting elements, but from what I understand is we're just reporting an intake the person, if the person is low risk or not low risk. We're not actually reporting on specifics of even where they fall within that range, just if they are low or not low, and if they're compelled. That we're not re-reporting. The reassessing that we have done has specifically been for treatment planning needs to show evidence of where else to target treatment plan. We, is my understanding, have not re-reported on somebody's criminal risk at like level of care change or discharge. That is, we're just reporting it in the take.
At least that's something encouraging.
Currently.
Well, and I do want to add to that, you know, when we're talking about these multi-health system tools, the LSIR screening version is just the screening version. So if you are receiving or completing the LSRNR, which is the more complete tool, I would question if both needed to be done. I think that you would not do the screening version if you have the LSRNR, because you have that full picture, which includes the risk level. So to that point, and also from a literature standpoint, you know, when we're doing the CPC program evaluation, we're looking at reassessment. So yes, Jared, I think that is why you feel that will come, is because the literature said, if I'm in treatment and I come in at a high risk, my hope would be that my provider I don't know that I'm phrasing that interestingly, but the goal would be that at some interval, my therapist would say, wow, she's really meeting the target goals we have for her antisocial relationships. And there's a reassessment that shows that I'm at moderate risk, that shows that I'm at low risk, which is opening up new groups to me. And that at the end of treatment, we're seeing this progression and reduction of risk level. So we can sort of anticipate a reduction of recidivism if people followed up with me after I completed treatment. So that I hope that is clear in terms of, yeah, there is a reassessment expectation from the literature for these risk assessment tools.
Yeah, I just worry about that. I feel like that's going to be taking up more and more and more of clinician time. And although it may be evidence-based and rooted in some of the data, I don't know. I worry about how often that kind of a thing could take place and whether or not it's realistic to believe that even a short screening version is going to be something that's going to be done.
Yeah, I think that's a reasonable concern. I'm interested to hear if others have similar concerns. I do want to draw back to Brett's point earlier and just this idea of, wow, when we used risk assessment, we realized that we were maybe overclassifying low risk clients, and that there's this sort of consideration of what treatment do folks need. I just felt like that was really interesting, that a risk assessment tool, a risk screening tool might allow you to not blanket target your clients, so individualize more, and that you won't be not over-treating because they may have other needs that fall outside of criminogenic need, like trauma, mental health, other things that we would consider responsivity and different treatment goals. But then that when we're looking at those criminogenic needs, you may not need to target all of them. And you most definitely, when you get that screening tool, should not be attempting to target all of the risks that they have at one time. So I kind of opening up some different lanes there. Does anyone want to pick up on that or have any thoughts?
I don't have any thoughts on that, but I have another question.
Please.
How do you know when to use the short version or the long version, the RNR versus the other one?
That's a great question. Brett, did you want to take that? Or so I don't know the screening version yet. I've just used the LSCMI, which is not even the full LSI RNR version, but our plan is just to use the screening version when switching to that and let that guide our low and not low placement. I think there will still be some areas identified as being, it will have some domains that identify, areas that are higher risk, but would probably just go with the shorter version. The LSCMI that we were trained in does have it's a really nice case management assessment and comprehensive case management assessment. It was very too long for us to implement as far as treatment. And we got what we needed just from the risk screening. Our plan is just to do the screening. And from our side, we're looking at screening as you have folks come in. If they are screening as low risk, you do not need to use a more intensive risk assessment tool with them. They should be moving into
are they what services then are they appropriate for your program? You know, what are they there for? What are their needs? Because it's sounding as though criminogenic targets or criminogenic treatment specific is not what they need. So you can route them to a different way. Maybe that's individual therapy, different services. But then if they're moderate to high, you're looking at these more in-depth tools as giving you more information. You know, what should you be focusing on when they are in treatment? And that's where the LSCMI, LSRNR, or other fuller risk assessment tools could come into play and help. Okay. Any other questions? I have a question. If not, okay. So implementation is challenging. So Brett, if maybe you can get us started on talking about, you know, what are some of the signs that you look for to let you know that your implementation is on track?
Yeah, so I talked about we had pre-built into our peer review process where our providers get, every therapist has a review of their charts by one of their peers twice annually. And so we built it into that tool, and the supervisors and directors get a summary of the areas that are being met and not being met. And after pretty quickly, we saw good scores related to the implementation of having risk assessed, and improved scores in the section of treatment planning around criminal risk. Took us, I would say, within 12 months, we were consistently, people were getting a check mark, yes, that their clients had been appropriately screened for criminal risk, that the LSI had been done, and really, we're seeing really good, meaningful scores with the treatment planning portion. Like I talked about before, our goal of doing that was because it was part of our directive. We needed to meet with the division. Interestingly, so we saw these improved scores on our peer reviews, and we just were not seeing them reflected in our site visits like we were getting scored low. I mean, we were not meeting the expectation on that, but our reviews were like, you know, 12 months apart. So we didn't, and so we was like, okay, well, we're really going to focus on it. After that first site visit, we're really going to focus on making sure this is done by the next year, which is when I became the director. And so it's just something that I really made sure was being done. And I was surprised that we had not met that measure. Come to find out the next year we didn't either, and then figured out that it was an error in our EMR that was not reporting on that data correctly, that we had been. So that was kind of our checks and balance system. It's sad that it took us 24 months to figure that out, that we were not meeting that. Now, luckily, there's some new checks and balances that we can find that stuff out earlier. But our first target was that peer review, and we watched that. I watched that closely. My supervisors watched that closely. We have really made that process as a way to check and make sure people are meeting their documentation, meets the basic directives and contracting requirements. But we've really tried to make that process a learning environment. It is peer-to-peer. It's not supervisors completing them and is a way for them to learn from each other. It's actually the way we try to work it is the person that is actually reviewing the chart. It's intended that they're paired with that person, the chart they're reviewing, to learn from that clinician's strengths specifically. So we try to foster that, just that as a kind of community, like of our process. And that has been super, super helpful and help people implement, being less resistive to implementation. And then the other thing is that one more thing, you know, I hear that less and as I know that implementation has gone a little more smoothly. So we have an internal checks and balance system. And then we have an external checks and balance system too.
Thanks for sharing that. Anyone else in the room started implementing the LSIR screening version or another tool? that you want to talk about?
I had a question. I missed the beginning of this. I couldn't find my link, so I got on as soon as I could. But I didn't hear, and Davis, are you guys, did you replace the Rant with this then?
Yeah, so we never did the Rant. The Rant, I was looking for that wording. We were getting those like printouts from our clients that were in drug court and a couple other programs, but we were never using that ourselves. So it didn't replace that, but we would, if we had been, it would have replaced that. Yes.
Because I've been trying to push for the LSRNR for years now. I work with the drug court program, and we've sat pretty stagnant on this Rant, which I don't feel it has enough information to implement a lot of change for the recidivism and the criminogenic needs of the clients that I work with.
You can actually help answer this question for me, because we got like the printout after Rant was done, and it just said if somebody was like high risk and high recidivism or high need, and I was like, that is great. They have to be that to be in the drug court program. So I already knew that. Is there any, like, in the beginning, I did say that I liked the LSI because it identified specific areas that were high risk to target. Does the Rant give that? Is there a part of the Rant that
does there is, and usually underneath where it says high risk, high needs, it'll have the bullet points on the certain parts that need to be addressed, or what qualified them for a high risk scoring. But it's a simple, like 12 to 15 question questionnaire that just, I don't think that it pinpoints enough on exactly what you're talking about, what we need to work on with that specific individual to help keep them on track in their programs.
Yeah, I do feel that.
I'll also add to that the Rant is a tool that is being promoted. As we've completed program evaluations, we've realized that we need to sort of recommend this as a system-wide consideration, that the Rant, because it only has one validation study that was completed, I believe, in Minnesota, we really don't know how it's working in our communities. So there either needs to be a push, multiple programs, with validation of this tool in Utah, or like the division is offering the LSIR screening version, which has been validated more widely. And so we can know that the instrument is more applicable to more people. So that's of consideration when looking at differences of tools, is how are they validated? Are they validated for your community, for the people you're serving? So yeah, so just to think about that with these tools.
Yeah. Thank you.
Yeah.
Friday, 8 a.m. All information and applications to apply for a certificate of
I hear. All right. Yeah. Okay. So we're coming up on the end of our session here. So grateful to you all for joining. Just started the conversation of implementing risk screening and assessment. I think some really great points are brought up about like what really does it mean when we're trying to use these in programs. Thank you so much, Brett, for joining us and considering what that might look like at a program in Utah. If you're interested, I'm just going to share my screen one more time, just so you all can consider joining me. We have open consultation hour for the Utah Criminal Justice Center. Our team offers open consultation hour for 1 hour every third Thursday of the month. Just putting that out there. The division, funds us to support your programs, whether you want us to help look at some of these practices of implementation with these screening tools, you want us to look into some research, come to that consultation meeting with any questions that you have or requests that you have. We're an extra pair of hands and eyes and ears to help support your efforts towards evidence-based practice, best practice with these justice-involved clients that you serve. Thank you all for your work. Are there any final questions?
I'm just curious if maybe next time, or if it's in your plan to kind of go over the actual screening tool. Yep. Because oftentimes, admissions does that, but then the client gets to us and they're like, okay, the LSI is 5 or 6 or 7. And that's all the information we get. And so like, we don't know like how the screening tool is used. You know,
Yeah.
I think it will be helpful not only for the therapist, but also to serve our clients better. You know, okay, what does that really mean? Okay, the LSI is 7. He answered yes to these questions.
Yeah.
Now what?
That is such a great point, and it really hits on this idea of implementation and how that needs to look across the program. You know, between your admissions, the folks that are doing intake, and therapists, peer support specialists, case managers, everyone should be feeling comfortable with this in order to make these a meaningful tool worth the time in doing them. So I think that's a great point. I'm kind of thinking of, you know, I'll take that back to the division. Brett mentioned that they're working on trainings for this tool to offer to folks, but I think there's also some power to, in program evaluations, we've seen some programs internally training on the LSIR screening version to make it feel more applicable to your specific program. So I'll look into that for future. Hoping to offer another strength series in 2 months. So that's in September as we head into fall. Please consider joining me this afternoon at open consultation, and also put your email in the chat if you want CEU credit for this. We will also be posting the video on YouTube if you have any staff or teammates or fellow colleagues that you think might want to watch this video and gain a CEU hour for the session. Thank you so much. And I believe that's it. I hope you have a good rest of your day.
Thank you, you too.
Thank you.
Jessica, is it the same Zoom link for the consultation?
Yeah.
Okay.
I'm just kind of keeping them open so that it doesn't get too like they get so many links.
Yep. Great. Thank you.
Thanks so much for your presentation. Appreciate it.
You are welcome. Thanks.
Bye.
Bye.
Thanks for being here, Deborah. Holly, thank you. Leah, thank you so much.